Today we are going to talk about brachial plexus. Brachial plexus is the most important topic related with the upper limb and probably one of the most complex topic, right? I will take my time, teach you slowly with crystal clear concepts. First, I will be discussing about the basics of brachial plexus, right? And I will explain every basic thing like roots of brachial plexus, trunk of brachial plexus, then there are divisions, there are cords, there are terminal branches and collateral branches, right? Every step we will have big discussion, right? Number one. But while we are talking about the brachial plexus network, which is basically a somatic plexus. Why I especially mentioned that it is a somatic plexus? Because most of the fibers which are present in the brachial plexus, they are related with they are somatic afferents and efferents, somatomotor and somatosensory, with few autonomic fibers, which we will of course discuss. But brachial plexus is not a autonomic plexus. The first thing is, what is brachial plexus? Brachial plexus is network of nerves, right, which originate from the neck, from spinal cord, from which segments of spinal cord fibers enter into brachial plexus. First of all, from which segments of, these are the segments of spinal cord, from which segments of spinal cord fibers go into brachial plexus. So basically, the fibers are coming from spinal segment, cervical segment 5, we call it C5, C6, C7, C8 and T1. It means how many cervical segments? From cervical spinal cord, we are having 5th, 6th, 7th and 8th segment. And from thoracic spinal cord, we are having just first thoracic segment. Now these are the segments of spinal cord from where the fibers are related with the brachial plexus, which are going to supply your hand, your forearm, your arm, your shoulder. And very good doctors know, of course, not only shoulder, also pectoral region and axillary region, right? So all these regions are innervated by the dominantly by the brachial plexus, right? And now, when I say that fibers are going from C5 to segment number C5, 6, 7, 8 and T1, I'm talking about most common pattern of fibers contribution. This is the most common pattern. But you know, as all of you have slightly different colors and slightly different heights, right? In the same way, in some people, brachial plexus may deviate from this standard typical situation, but still that is normal. For example, in some cases, brachial plexus receives fibers not only from C5 but also above it, that is C4. Okay, I write it here, C4. C4 fibers are also going, their significant contribution from C4 segment of spinal cord, right? If there is significant contribution of C4 to brachial plexus, significant contribution, right? In that case, usually we call it prefixed brachial plexus, because it is fixed before the typical onset of fibers, which is C5. So prefixed. And if some other people, what happened, that fiber from C5 are less, right? And from T2 fibers are added to the brachial plexus, right? And if you have a person like this, then we say this is post-fixed type of brachial plexus. Again, listen. What is brachial plexus? Brachial plexus is basically a network of neurons which is originating from, or neuronal fibers which are originating from the neck, from the cervical spinal cord, and also from the upper thoracic. Most classically, the fibers contributing to the brachial plexus are coming from spinal cord segment number C5, C6, C7, C8, T1. But in some people, there is significant contribution from C4 and less contribution from T1. That condition is called prefixed brachial plexus. And there are some other people, that is also normal. You can say that fibers from C5 are contributed to the brachial plexus in less amount, but significant amount is contributed from T2 spinal cord segment to the brachial plexus. Then we say there's post-fixed brachial plexus, right? Now, the very common way to remember this pattern, which I'm going to explain with this diagram thoroughly, that we say that really tired, this is mnemonic, or you can say, just remember, really tired, yes, drink coffee beans. It's a little funny. Who is going to drink the beans? And it's really hard to drink the beans, people. But just for us, really tired, drink coffee. It should be enough. But if you are really super tired, maybe you have to take some coffee beans also. So really tired, drink coffee beans, right? Now, what do I mean by really tired? The R of the really means for the roots. These blacks are the roots of the brachial plexus. Really tired, T is for these trunk. These green part are basically trunks of the brachial plexus. Really tired, drink. Don't drink that thing what came to your mind. I'm talking about drink coffee. So drink, this D stands for deviance, right? So really tired, drink coffee. C stands for cords, C-O-R-D-S. These are the cords of brachial plexus. And in the end, here it is, what is it? Branches, right? Terminal branches basically. And so we can say beans. This B is for branches. So there are so many mnemonics available on Google, but one of this is that if you are how to remember that, first of all, brachial plexus explanation in most of medical literature, they start with the roots, right? So there are roots, there are trunks, then there are deviance, then there are cords, and then there are then there are beans. No, then there are branches. Actually, these are terminal branches, because on the way from the component of the brachial plexus, there are collateral branches also, which we will discuss later, right? So we will start our lecture from really. Really mean roots, right? Roots of brachial plexus. Read it brachial, not bra. Roots of brachial plexus. Now, here's a little complication, that in medical literature we start that roots are here, right? But from where the fibers are coming to the roots? We say from the spinal cord, right? But there is another thing. There are roots of the brachial plexus and there are roots of the spinal cord itself. So how to differentiate? Very good doctor, first of all, we go into detail of brachial plexus. If you are going to be a very good doctor, you must know the difference between the roots of brachial plexus and roots of spinal cord. They are not one and the same thing, right? So let's differentiate first of all, what are the roots of spinal cord and what are the roots of brachial plexus. Let's start, we can take any diagram. Okay, we concentrate on this diagram, this wire. Now, this is spinal cord section, T1. Or okay, why don't I draw it myself? Look at here. This is a segment of spinal cord. Let's suppose it is C5, right? And yes, here it is spinal cord, and here it is interior spinal fissure. This is posterior spinal sulcus. This is spinal canal. This is spinal canal. Around it there is vertebral canal, right? And this is gray matter. This is gray matter, right? And around it there is white matter. Gray matter has cell bodies. Now, some of you who are very intelligent, they know that gray matter, which is interiorly present, it has cell bodies which belong to the motor system. So fibers which are coming from cell bodies of interior horn of the gray matter of spinal cord, the motor fibers. Now these motor fibers, they are exiting from here, right? And if you look at the posterior gray matter of the spinal cord, we call this posterior horn. This was interior horn of the spinal gray matter. This is posterior horn of the spine. Now, posterior horn of spinal gray matter is basically connected with the sensory system, sensory neurons, the neurons which are collecting sensory information from the arm, like neurons which are bringing touch, pain, temperature, vibration, and other sensations, right? Pressure. Now, so this is on the back. This is area which is gray matter, which is connected with sensory fibers, and anterior gray matter is connected with the motor fibers. Now, sensory fibers have their cell bodies outside, right? For example, if this is one sensory neuron, it has one process which is going to centrally, right? Going to posterior horn, and one going to the peripheral tissue, for example, to the receptors present in upper limb, right? Now, this collection of cell bodies, which are outside the central nervous system, they are called ganglion. And these fibers from the ganglion, these are from fibers from the ganglion having central extensions and taking the information to the central nervous system, to the posterior horn of the spinal gray matter, and here are the other fibers which are going to the periphery, right? So now we have a system. There's motor fibers which are connected with the spinal cord, and there are sensory fibers which are connected with the spinal cord, right? Now these motor fibers which are connected with the spinal cord and they are exiting here, these are called motor roots from spinal cord. Please don't confuse these motor roots of spinal cord with the roots of brachial plexus. We have not yet reached to the brachial plexus. We have just started with the spinal cord. So from the spinal cord, anteriorly, which root is coming out? Motor root. And with the spinal cord, posterolaterally, which nerve is coming out? Which root is coming out? Sensory root, right? Or dorsal root. Now, this is motor root, or ventral root or ventral root. This is sensory root or dorsal root. And of course, dorsal root has dorsal root ganglion. It has dorsal root ganglion. Ventral root does not have any ganglion. Now, what really happens? That they come together and they fuse with each other, right? And all these sensory fibers and motor fibers which are present in the ventral root and the dorsal root, all these fibers fuse with each other and they make another neuronal bundle, right? And this neuronal bundle, this green one, right? This is actually spinal nerve proper. This is spinal nerve proper. This is very important to understand. So when these are not brachial plexus roots, right? I'm going from very basic, that from where the fibers come to the brachial plexus root. First of all fibers are connected with the spinal cord, right? And there is interior root of spinal cord, which is interior motor root, and posteriorly sensory root. So interior root and posterior root, or ventral root and dorsal root. Root of what? Not root of brachial plexus, root of spinal cord. So they exit and move laterally, and then they fuse with each other, right? And they make a neuronal segment which is having mixed fiber. Now this neuronal segment is basically your proper spinal nerve. This is your proper spinal nerve. Now, what really happens that this spinal nerve, which is having motor fibers, of course, motor fibers have been present into it, and it was also having sensory fibers, right? So this is a mixed nerve, right? With little more traveling, usually 1 to 2 centimeter, depending upon location in the spinal cord, this typical spinal nerve or spinal nerve proper will divide into 2 divisions, right? One division will go backward, one division will go backward, right? And other division will move forward. This division of spinal nerve proper, which has gone backward, that is called dorsal ramus. This is called dorsal ramus, or right, this is called dorsal ramus. And this root, this is very, very important for us. These fibers from the spinal nerve process, which are moving to the anterolateral part of the body, right? They are moving to the posterior part or back. Now, they are moving anterolateral. Both of these are having mixed fibers, right? This is called dorsal ramus. This is called ventral ramus. Ventral ramus, right? Now, dorsal ramus also has motor fibers, right? Dorsal ramus also has motor fibers, and ventral ramus also has motor fibers, right? In the same way, from dorsal side of the body, back of the body, sensory fibers are collecting the sensation, taking to the nerve proper, and then to the dorsal spinal cord root. In the same way, ventral ramus, that is also collecting the sensory fibers. Now, what we can say, this diagram is more beautifully made here, right? For example, here it is shown segment number C5 or 6. Now, in this segment number C5, spinal cord is there. We say there is interior gray horn. From there, this, yes, what is this coming? Ventral root, which is also called motor root. This is dorsal root, or which is also called sensory root. They unite together, right? And they make what? Spinal nerve. And this spinal nerve with little more extension divides into dorsal ramus and ventral ramus. Now, these fibers, mixed fibers, which are going into ventral ramus, right? These ventral rami receive also at C5 level or 6 level or 7 level or 8 level, they receive autonomic post-ganglionic sympathetic fibers, right? They are receiving, and these fibers which they are receiving, later on we will discuss from where they are coming, but these fibers which they are receiving, right, these are sympathetic fibers, post-ganglionic sympathetic fibers coming from the sympathetic paravertebral sympathetic chain, right? These post-ganglionic sympathetic fibers add to the ventral, what is this? Ventral ramus, and some of these fibers go to the dorsal ramus too. Now, what we can say that from here, if we started from this point, this was ventral ramus, right? Again, this was ventral root, right? Which was pure motor. This is ventral ramus, which is having motor fiber as well as sensory fibers, and motor fibers are somatomotor fibers, right? Yes. And they are somatosensory fiber and sympathetic postganglionic fibers also. Now, these fibers, this is your interior ramus, right? This interior ramus, right? This interior ramus is moving more laterally, and this is called root of brachial plexus. This is called the root of brachial plexus, and this was the root of spinal cord. So every doctor must be clear when we talk about brachial plexus, when we are talking about the roots, first of all, your mind must be very clear. Are you talking about spinal cord roots, or you are talking about brachial plexus roots? They are very different things. Thank you very much for an anatomist who made this situation to confuse innocent people like me and you, right? But so now it's worth understanding. If I draw this is which root? Spinal cord, ventral root. What is this root? Spinal cord, dorsal root. So these are roots. This is purely motor, that is purely sensory. Then roots go into what? Spinal nerve proper. Then spinal nerve proper makes two branches, dorsal branch, which is going backward to the back muscles and back skin, and make a ventral ramus, which also receives, in case of autonomic, in case of these ventral rami, which are in the brachial plexus, they are receiving this gray ramus, and these gray ramus, this is the gray ramus, which is bringing fiber here, right? This gray ramus is basically bringing autonomic fibers, right? So these were the spinal cord roots. This is spinal cord, spinal nerve proper. This is dorsal ramus of the spinal nerve proper, and this is the ventral ramus from here going up to here. Yes, all this is What is this? This is ventral ramus coming from T1. Now this ventral ramus is basically, if it is coming from C5 ventral ramus, this one, or C6, what is this ventral ramus? C7 ventral ramus. And what is this ventral ramus? C5 ventral ramus. And what is this ventral ramus? C8 ventral ramus. Now these ventral rami or anterior rami are called brachial plexus roots. So when someone mentions that he is talking about brachial plexus roots, actually that person is talking about ventral rami of those spinal nerves which are originating, which are taking fibers from C5, C6, C7, C8 and T1 spinal segments, right? When someone say brachial plexus starts from roots, yes, our nomenclature say brachial plexus starts from here. But actually, we should know from where the fibers are coming to the brachial plexus and from where the fibers are going from the brachial plexus. So if this is the root or ventral ramus, actually on one end it is going to the periphery and on other end it is going to the central nervous system, right? And never ever confuse spinal cord roots with brachial plexus roots. Spinal cord roots are ventral root and dorsal root, right? And ventral are purely motor and dorsal are purely sensory. But when we talk about what are the roots of brachial plexus, we will say these are anterior rami having mixed neuronal fibers, majority somatic fibers. That is why it is called somatic plexus. But they do have some autonomic fibers, sympathetic fibers, right? Now, this root has mixed fibers. Which mixed fibers? Let me make it clear. This root, number one, it has motor fibers in it, which are going to the muscles, to the upper limb. Now, they are alpha motor neurons and gamma motor neurons. Then, there are sensory fibers which are also present in this root. And they are moving from periphery to the center, right? Bringing sensations or information to the central nervous system, right? So, there are what type of fibers? They are somatosensory fibers. They are somatomotor which are moving towards the periphery to the muscles, and there are somatosensory which are moving to the center. Both of them are moving through the brachial plexus roots, which are basically ventral rami of spinal nerves which are derived from spinal cord roots of spinal cord segments of C5, C6, C7, C8, T1. It's worth repeating. Believe me, it's worth repeating, because when I will finish the whole basic structure, I'm going to teach you at least 20 different clinical situations related with brachial plexus. The easiest way, people say just this is somatic neuronal plexus originating from the neck and moving through the axilla and innervating the arm. That is right, but that is too simple. For a very good doctor, you should know more basics in detail so that you can apply the clinical conditions. We are going to talk about more than 20 clinical situations which can be produced by some pathology within the basic structure of brachial plexus. Basic structure means problems with the roots or with trunks or with divisions or with the cords or with terminal branches or collateral branches, right? 20 clinical situations that will include 10 pulses. 10 pulses. Especially I will talk about very special stress on the Erb's palsy, right? And clump case palsy. Actually, they deserve a dedicated lecture, and that will be given during this series in the oncoming lectures. In the same way, not only I will talk about pulses, about 10 pulses, I will talk about 4 special points where we give regional anesthesia related with the plexus of brachial system or brachial plexus, right? Especially I will teach you scaleni, regional block and axillary regional block. Then there are certain syndromes related with brachial plexus. For example, we will talk about thoracic outlet syndrome and problems related with clinical problems related with brachial plexus. Even we will talk about Pankos tumor and its involvement with the lower part of the brachial plexus. But only those doctors can understand clearly those almost 20 clinical situations who really understand the basic structure of and brachial plexus. So let me focus on it. It might take long time, but it will stay with you for lifetime. It's not like studying brachial plexus in 20 minutes and forgetting in 20 seconds. Let's come back. Now, we have just made a concept clear. What are brachial plexus roots? It's worth repeating, as I said, brachial plexus roots are having sensory fibers, motor fibers, and autonomic fibers, and these roots are basically what? They are ventral rami. They are ventral rami of spinal nerves, which are derived from ventral and dorsal roots of which are themselves coming from special spinal cord segments. And which are these special cord segments? In majority of the patient, these are cervical 5, C5 spinal cord, C5, C6, C7, C8, T1. Some people have more fiber from a significant contribution from C4 segment, right, and less from T1. We call them prefixed brachial plexus. And in some people, right, they are having less fiber from C5 and more fiber from T1 and even from T2. That is called post-fixed, right? Post-fixed brachial plexus. Okay, I will not write BRA. Brachial plexus. And here above, which will be there? Prefixed brachial plexus. But classical brachial plexus, when next time someone talk to you that it is having C5 root or this consists of 5 roots, C5, 6, 7, 8 and T1, he is talking about exactly what? He is talking about the ventral rami of those spinal nerves which are taking origin from ventral and dorsal spinal cord roots related with the special spinal cord segments, especially from C5, 6, 7, 8, T1, right? Now we understand what are these roots. Now these are basically, because it is cervical plexus, segment, this part of the spinal cord is present in the neck. So naturally this will be outflowing, this whole system is outflowing from the neck. And if it is outflowing from the neck, where it has to go? To the arm. It is originating from the cervical and upper thoracic T1 and making a special type of network. We will go into detail, and eventually terminal branches are going in the arm, right? And some on the way, Before these blue terminal branches, there are these brown collateral branches, which are supplying, many of them are supplying the axilla and pectoral region, right? Of course, in axilla scapular region, you are right. In axilla pectoral region is anteriorly and scapular region is posteriorly, right? Now let's focus on, we continue our focus on this area, right? Here's the vertebral body, right? And here is our spinal cord. What is this? Anterior root. This is posterior root. And what is this? Dorsal root ganglion. And they fuse together. And here, what they are making? Spinal nerve proper. And what is this? Dorsal ramus. And what is this? Ventral ramus. Now, why I brought you to this diagram? To emphasize the anatomical relationship. Basically, these roots, spinal cord roots, they meet each other near the intervertebral foramina, and from the intervertebral foramina, mixed or proper spinal nerve is coming out, right? So these roots, what are these roots? Spinal cord roots. They are actually before the, what is this? Intervertebral foramina. And after that, what is there? Typical spinal nerve. And after that, we will have, if it is C5, 6, 7, 8 or T1, then this ramus interior will be called the root of the brachial plexus. A little more interesting detail. Let's come here. Look at these roots. This was ventral root. This was dorsal root. Here, there is, okay, I'll make it black. These are meninges around it. You know, there's dura mater, and then there is, what is this? Arachnoid mater, and here is pia mater, right? So there are meninges around the spinal cord. Meninges give a sleeve, right? Meninges give a sleeve which is going with the roots, with ventral root and also with the dorsal root. And here they fuse with each other. Actually, they don't fuse with each other. Actually, this dura mater, the outermost layer, extend up to the roots, and there it fuses with outermost connective tissue layer of the spinal nerve, and that this special, I'm making it very thick, this connective tissue covering, protective covering on the spinal nerve, this is called epineurium. This is called epineurium. Now, basically dura mater here and epineurium here, they fuse. What is the importance of this? It has a huge clinical importance. It means that if dura mater is coming up to this, and here is dura mater, and structures up to here are within the dura mater, it means they are in the central nervous system. It means they are in the central nervous system. It means your ventral roots and dorsal roots of spinal cord are not the part of peripheral nervous system. They are part of the central nervous system. What does it mean? It means that if someone has meningitis or some central nervous system disease, that can extend to the ventral root and dorsal root. If you have some pathology, right, which is exclusively involving central nervous system, then this can also involve anterior root and posterior root. And those pathologies which exclusively involve peripheral nervous system, they spare these two parts, they can come up to here, right? Because spinal nerve proper is the onset of peripheral nervous system, right? So when we see the diagram of spinal cord and we see the roots should be considered anatomically and functionally part of central nervous system, and when dura mater over the roots meets with the epineurium and proper spinal nerve is formed, then we say this is the onset of peripheral nervous system. So this plexus, these ventral rami, of course, they are covered by the epineurium, right? So they are part of the central nervous system. So this is peripheral nervous system. So this is one more difference in the roots of spinal cord and roots of brachial plexus, right? That roots of brachial plexus are of course belonging to the peripheral nervous system, but few doctors understand it clearly that roots of the spinal cord are part of the central nervous system. Is it clear? Now, once we are done with this, we have also seen what anatomical relationship, that exactly where are these roots, right? Spinal cord roots, they are in the spinal vertebral canal, and what is this coming out? Spinal nerve, that is spinal nerve proper is coming out of intervertebral foramina, and then it divides into dorsal ramus and ventral ramus, and ventral ramus from C5, 6, 7, 8 and T1 are called roots of brachial plexus. Thank you very much. This was one of the very important points to clearly understand for your lifetime the difference in these two roots. Okay, so you can call it ventral rami or you can call it brachial plexus roots, right? Don't call it just roots, right? They are brachial plexus roots. Now, once they come out, these roots come out, root from the C5, all fibers in the C5 and C6 root. This is C5 spinal segment. This is C5 root, right? Now this C5 root and C6 root, they fuse with each other and make an upper trunk. They fuse with each other. I don't know, it's some sort of, I don't know, mating or loving or what, I don't know. But anyway, C5 and C6 love each other so much that they make a united front, united bundle, right? So this bundle is upper trunk of brachial plexus. And this C7, it is very arrogant, right? It doesn't like to mate or mix, and but eventually somewhere it will in future mix, but not here. Here C5 does not like C7 root does not like to fuse with C6 or with C8. So it goes on its own, solo flight, right? This loner C5 root, right, does not continue as such, and this part which continues as such, we say that this root is now converted into trunk. Which trunk? Middle trunk. This is the middle trunk. Here it was upper trunk. So upper trunk has fibers from C5 and C6. I must write. The fibers here are from C5 and C6. Right? But here, the middle trunk, it has fibers only from C7, right? Okay, I will make it here also. Here the fibers are only from C5 and also fibers from C6, right? So what is the root value of upper trunk? C5 and C6. And what is the root value of middle trunk? C7. And now we are left with these two roots, C8 root and root which is T1 root. They are also a little bit romantic. They fuse with each other and mix with each other. This mixing or mingling of these fibers eventually make one trunk or one bundle, right? And this united front or united bundle, right, which contains the fibers coming from C8 and T1, both of these fibers are found here together, anatomically one structure. This is called lower trunk of the brachial plexus. So let me make it here for you. Which fibers should be here?
C8 and T1.
There should be C8, yes, C8. And plus it was also having fibers which are connected with which system? Thoracic spinal cord segment 1, T1, right? So these are the root values. Yes, please.
Sir, is there any inter-root difference?
Yes, there is. It's a very important question. She's asking that these 1, 2, 3, 4, 5 roots are all of them identical, or are they somewhat different from each other? Yes, some of them, especially C5 and T1, have significant differences. I will go back. You know, in lecture I keep on moving back and forth so that it sticks to your mind depending upon the amount of gray matter you have, right? Gray matter mean in the cortex, cerebral cortex. Now, first, so C5 and C6 fibers are present in upper trunk, C7 fibers are present in middle trunk, and C8 and T1 fibers are present in lower trunk, right? Now, today we keep on studying and focusing on roots and trunks. Here, she has asked a very valid question. Is there any difference between these roots, or all roots are similar or identical? For an average doctor, they are similar. But you know, all doctors are not average doctors. They are exceptional doctors, right? And they know the difference. And that difference also translates into different clinical manifestations. Let me tell you. Number one difference is this C5 root. It gives branch. It gives some fiber to dorsal root is here. Don't consider this dorsal root. From the ventral root, it gives some fiber to phrenic nerve. Now, phrenic nerve root value is C3, C4, and C5. These are the fibers which are making phrenic nerve, and this nerve is going down. So C5 gives fibers a twig to, what is this? Phrenic nerve, and this phrenic nerve, which has C3, 4 and 5, and it will descend downward, and for example, if it is right phrenic nerve, eventually it will mainly supply right hemidiaphragm. Right hemidiaphragm. Is that right? Of course, from all other, sorry, we come to the roots. From all other roots, there's nothing going for the phrenic nerve. This is one difference. Secondly, C5 has few things very special. Not only it is the uppermost in most cases, right? Number one, it can give branch to phrenic nerve, which are not given from C6, 7, 8, T1, even though phrenic nerve has to go down. Right? There's another difference. C5 root has two collateral branches. C5 root has two collateral branches. One branch is this one. This one. This is originating from the root, right? This nerve is called, this branch or this nerve which is originating from C5 root, right? And nothing corresponding is originating from any other root. Only C5 is giving this branch. This branch is called dorsal scapular nerve. Very good. So now we have studied first dorsal scapular nerve. Actually, C5 is here deep, right? And C5 will give dorsal scapular nerve, which will move dorsally and backward and descend on the back and apply the muscles rhomboid major, rhomboid minor. These are muscles on the back, and levator scapulae. These muscles, right, they retract the scapula, right? So C5 has number one very special thing. It gives branch to the phrenic nerve, and other special thing, it gives origin to the dorsal scapular nerve. We will later on study this nerve in detail, but not now, and its clinical situation also. So this is, what is this? Dorsal scapular. Now we can see another thing, that C5 is also giving branch here, this branch. But these fibers which are going on the back of the brachial plexus receive fibers from C6 also. They also receive fibers from C7. This nerve is really long, and it has, I don't know, they have wings with it. So this long nerve which is going down, right, receiving the fibers from C5, 6 and 7. But exception is not from C8 and not from CT1, right? Now these fibers which are making a bundle, neuronal bundle, C5, 6 and 7, they descend downward on the medial side of the axilla and they innervate. Yes, innervate which muscle? Very important muscle. Very, very important muscle. Not latissimus dorsi. Serratus anterior. Say it loudly. Serratus anterior. And this long nerve is called long thoracic nerve. So root value, now look at it. The root value of long thoracic nerve is, it is taking from C5, 6 and 7. So it has C5, 6 and C7. So it's not difficult to understand if you understand the basic structure, right? Root value of long thoracic nerve is C5, C6 and C7. Why it is so important to understand? Because if these roots are damaged, then long thoracic nerve is also damaged, including many other damages, right? And you can guess, what is the root value of dorsal scapular? C5. C5. Because it is taking origin only from here, so this is C5 root value. It is so easy. I think these root values are so easy that they should not be taught. Am I right? You don't agree with me? Okay. Then I continue teaching you. So now, the very special question which was asked, that are these roots identical or there are some differences? I was telling the differences, and due to this question, we are able to learn a lot, that C5 has something special. Number one, it gives a branch to phrenic nerve, which others roots don't give. Number two, it gives dorsal scapular nerve, which other roots don't give. Number three, it gives a contribution to long thoracic nerve, but C6 also gives contribution here, and C7 also gives contribution here, and this makes a long thoracic nerve. Why wings are made here? I will teach you later that when long thoracic nerve is damaged and which muscle is paralyzed? Serratus anterior. Then such person who has long thoracic nerve damage and serratus anterior is not working, its innervation is lost, then it cannot protract the axilla. It means if this person will try to push the wall, right? Don't tell me wall will fall. When this person will try to push the wall, one scapula which is having, what is this? No injury, right? This, and serratus anterior is working, serratus anterior will try to swing the arm forward by swinging the scapula around the thoracic lateral side of the thoracic cage. But here, because serratus anterior is not working, so scapula medial border is unable to move forward. Rather, with pressure, this will bulge backward and it will look as if this person is like an angel having a little wing here. Right? That is why I have made their wing. That if this nerve is damaged, then winged scapula will be there, right? But I will teach you in detail the different causes of injuries to the long thoracic nerve, the root of the long thoracic nerve, anatomical relations of long thoracic nerves, and clinical significance of any damage to the long thoracic nerve later. It was just a little information. So now you have seen these were something special about C5. Then there is something special. We need to come back here because there is something very special about T1 which make the T1 different from others. Let's suppose here I make your central nervous system. Of course you have one, I'm very sure, and here is your pons and medulla and spinal cord, right, and cerebellum. You must have a nose also, am I right? And beautiful eye. Okay. Oh, what is happening here? This should be here and here. Now, what is really happening that fibers, here is the spinal cord, right? This is C5, 6, 7, 8, and here it is T1. Okay, I will make the T1 black. This outflow, these fibers which are coming out, eventually their ventral rami will make the brachial plexus, right? But there is something special about the autonomic nervous system. You have to listen carefully because it's a little tricky. Autonomic nervous system, let's talk about sympathetic. It has two parts, parasympathetic and sympathetic. Actually, sympathetic fibers are descending downward from the hypothalamus. From here is hypothalamus, which is the highest center for our autonomic nervous system, where there are sympathetic centers and parasympathetic fibers. From here, fibers descend downward, and these fibers are basically polysynaptic autonomic descending fibers. Out of them, some fibers end on special neurons which are present in spinal cord as lateral horn. Lateral horn means we have made spinal cord here. Okay, I will make the spinal cord again. If this is the spinal cord, here is your ventral and dorsal root. This was ventral root. What was this? Sorry, ventral gray matter. This was ventral gray matter, and this is dorsal gray matter and dorsal gray matter. But from T1 up to L2, spinal cord has initial aggregation of cell bodies on the lateral side of the gray matter. This is called lateral horn. This is called lateral horn. These lateral horn are having cell bodies of preganglionic sympathetic outflow. So from here, from T1 level, from T1 up to L2 or L3, right, the fibers which are going out, not only they are motor and sensory, but they are also sympathetic fibers. So spinal sympathetic outflow is called thoracolumbar outflow. What is this? From thoracic segments and upper to lumbar segments. From here, the fibers which are coming out, right, they are having not only here T1. This T1 has lateral horn here and lateral horn here. From here, special sympathetic fibers will come out. Okay, I don't know what color I should make now. Okay, I will make it red or black. These are special what? Sympathetic fibers from the lateral horn are coming into ventral root. We call it visceromotor fiber, sympathetic motor fiber. And these fibers will go into ventral root, not brachial root, brachial plexus root, ventral root, then mixed nerve. Then they also go divide into dorsal and ventral what? Ramus. And from this ramus they go out into a ganglion where they may terminate, or some of these go out and go down, and some of these fibers go upward. Now, these three fibers which are going to this ganglion, this is sympathetic ganglion. It is on the side of the what? It is on the side of the vertebra. So it is called paravertebral sympathetic chain. And this ganglion belongs to that parasympathetic sympathetic chain. Now, this ganglion is receiving preganglionic fibers from lateral gray horn. And this lateral gray horn extends from in the spinal cord from T1 level up to L2 level. It means all the spinal roots which are coming out from T1 up to L2 are bringing sympathetic preganglionic fibers which are myelinated. Which are myelinated. These myelinated fibers, right, they go to the nearest, what is this? Ganglion. Some of them terminate there. Some of them go and terminate in some upper ganglion. Some of them go and terminate in lower ganglion. And some of them move towards viscera. We will not go into detail that. But what I am trying to say that T1 has this special outflow. What is this outflow? Sympathetic outflow. Autonomic outflow, to be more specific, sympathetic outflow, sympathetic motor outflow. This fibers, because they are heavily proper good, not heavily, but they are significantly myelinated. So this connection between ventral ramus and what is this? Ganglion. This connection is called white ramus. So white ramus belongs to autonomic nervous system. So what is white rami? Some people call it white ramus communicans. White ramus communicans brings myelinated preganglionic fibers from the lateral gray horn, which extends from T1 to L2, and when these, what is this? These fibers come into white ramus, it is connected to ganglion. And whatever fibers come here, some of them terminate here, and from there, postganglionic go. Some of them go to a ganglia below, and from there, postganglionic go out, right? Some go up and then go. But some of these postganglionic, after the ganglion, second neuron of sympathetic nervous system re-enters here into where? Into ventral ramus. What does it mean? Listen carefully. From lateral horn, sympathetic fiber from T1 going out, right? Go to dorsal horn, and also, but forget about dorsal. Mainly they come on ventral horn. Then from ventral horn they shift to, what is this here? Through the white ramus communicans to the paravertebral ganglia, and from there second fiber which are less myelinated. So they look somewhat gray. They don't look white, they look grossly somewhat gray. So these second order neuron, or we can say postganglionic neurons, which are less myelinated, they make a bundle, and that bundle takes second order these postganglionic neuron back to the ventral ramus. And because they are less myelinated, they are called gray ramus or gray rami communicans, right? So here, very important thing. If we say dorsal ramus, we are talking about spinal nerve proper ramus going backward. If we say ventral ramus, then we are talking about spinal nerve proper ramus moving anterolaterally, right? And if we say white ramus, it means fibers from the ventral ramus of spinal nerve are going towards paravertebral ganglion, and these are preganglionic fibers. And if fibers from paravertebral ganglion are going back and re-entering into the ventral ramus, right, then we say these are gray ramus. So don't confuse ventral and dorsal ramus, which are the rami derived from the spinal nerve propers, and don't confuse them with the white and gray rami, which are related with autonomic nervous system. And white rami are the preganglionic fibers coming towards the vertebra, and gray rami are postganglionic fibers going back to the ventral ramus. Now, through the ventral ramus, these gray fibers, they will go eventually to the terminal branches. Now, this terminal branch must be receiving, what is this? T1, T1 segment interior horn motor fibers. And this branch, actually this is ulnar nerve. This must have some sensory fibers which are again going back to T1. What is this? Sensory root and dorsal gray matter. And it must have some sympathetic fibers which are from the gray, what is this? Gray ramus entering and going through ulnar nerve. And wherever ulnar nerve goes, it gives somatomotor fibers, it gives, yes, no, somatomotor fibers, somatosensory fibers, and in addition to that, sympathetic motor fibers. Sympathetic motor fibers are basically which are going through gray ramus back to, what is this? Root, brachial plexus root, and then going distally. They actually give innervation, sympathetic blood supply to the blood vessels, which are called vasomotor fibers. Sympathetic supply to the erector pili muscle, which produce goosebumps. So they are called pilomotor fibers, and they also supply to the sweat glands, which is called pseudomotor fiber. So this gray rami, which is going here, it is taking postganglionic sympathetic fiber into the system, eventually going to supply the autonomic fibers, sympathetic fibers to the blood vessels, vasomotor fiber, to the erector pili, that is pilomotor fiber, to the sweat glands, which are pseudomotor fiber. This pseudo is without P, S-U-D-O, pseudomotor fibers. Is that right?
Yes.
Now, in this regard of white, what is this? White ramus. T1 is very unique because white ramus is coming out of T1 root, right? But come back to this diagram. Here was sympathetic outflow from T1 to L2, but there is no sympathetic outflow at level of C, C5, 6, 7 and C8. There is no sympathetic outflow through this system. But when this system is going distally, somewhere sympathetic fiber should be added here. You are understanding? But they are not coming directly from the central system. So what happens that if we take these sympathetic fibers which are coming from T1, from white rami, they will come to this ganglion, right? Then from the gray rami, they will go back to T1 level and go back, and they supply three type of fibers as I showed: vasomotor and pilomotor and pseudo SUDO, pseudomotor. But the problem is that those areas of the arm which are supplied by other branches like radial branch or like musculocutaneous branch or like median branch, how they receive their sympathetic outflow. Or more accurate question should be that fibers which are going through C5, 6, 7, 8, right? They don't bring from here what? Sympathetic outflow. So they don't have white rami. So out of all these, white rami is present only on T1. This is an exception. C1, C5, C6, C7, C8, T1. They do not have, actually C5, C6, C7 or C8. They do not have white rami communicants, right? But T8 has white rami communicant. Now, T1 has white ramus communicants. So this is something very special about the T1, and this is a unique thing which differentiate T1 root of brachial plexus from all other roots of the brachial plexus. Now, actually, I was telling you the fibers came sympathetic from here. This was what? White ramus. Sorry, this was white ramus, and from here the fibers went back. I will make it more clear so that it really becomes crystal clear. We are now focusing only on the sympathetic fibers which are coming out of T1. These fibers, preganglionic, will go to the ganglion. Now what is this? This is white ramus. What is this? White ramus. From here, gray ramus fibers will go back and innervate to the supply sympathetic innervation to the related dermatomes and myotomes, right, and vasomotor system. But what about the upper things? Actually, this is T1 ganglion. What is this? T1, which ganglion? Sympathetic ganglion. Above it, there is also another ganglion, which is inferior cervical ganglion. Inferior cervical ganglion. Here is middle cervical ganglion, and here is, it is in the neck, right? Nose should be somewhere up. You have a little nose. Okay. So this is superior cervical ganglion. Now, these fibers which were coming from here, preganglionic, some of these preganglionic fibers, which they go up, some of them terminate at inferior cervical ganglion, some of them continue and terminate at middle cervical ganglion, some of them continue and terminate at superior cervical ganglion. Is that clear? Now, in this way, these ganglions are connected with each other, right? What was this ganglion? Thoracic ganglion, then inferior cervical ganglion, then middle cervical ganglion, then superior cervical ganglion. Now these ganglions are connected with each other from the fibers which are mainly having outflow system from T1 system, right? T1 spinal lateral horn. And as they are ascending upward and at different levels of ganglia, they terminate, and from there the postganglionic fibers go out. Postganglionic fibers go out. Now these postganglionic fibers are white ramus or gray rami? Gray rami. They are gray rami. So actually what happened? This, for example, this is inferior cervical ganglion. Gray rami from inferior cervical ganglion give contribution to, yes, this is one gray ramus. Contribution to C8 we already discussed, which is natural. Also, what is this? C8, T1, C8 and C7. So this is what I'm showing here. that these things are basically gray rami. This is gray ramus, this is gray ramus, which consists of post-ganglionic sympathetic fibers, which are coming either from T1 ganglion or from inferior, or in these two cases, or from the inferior cervical ganglion. Now listen carefully, very carefully. In many people, inferior cervical ganglion and T1 thoracic ganglion, they fuse with each other. When they fuse, in majority of the people, they fuse with each other. Very happy. United front. When these two ganglion fuse with each other, they are called stellate ganglion. Stellate ganglion. In that case, we can say the gray rami from the stellate ganglion, which include the thoracic ganglion and also inferior cervical ganglion, these gray rami are giving postganglionic sympathetic fiber to the ventral ramus or root of the brachial plexus at T1, root of the brachial plexus at C8, root of the brachial plexus at C7. And from middle cervical ganglion, postganglionic fibers, they go out and some of them go and add to C6 and some other go out and eventually add to the ventral ramus of C5. Here I'm showing in these areas that these are the gray rami of C7, C6 and gray ramus of C5. So now what did we learn? Something very special. That's even though for most of the time we are saying brachial plexus is a somatic plexus because majority of the fiber in the brachial plexus are somatic motor and somatic sensory. But they do have some vasomotor fibers, pilomotor fibers, pseudomotor fibers, I mean sympathetic fibers. And now we have told you from where these fibers come. The postganglionic fibers are added to lower three, C7 root, C8 root and T1 root from the gray rami which are derived from stellate ganglion. And postganglionic sympathetic fibers are added to C6 root and C5 root from middle cervical ganglion. And upper cervical ganglion, listen, upper cervical ganglion, it gives fibers to head and neck and other structures, right? For example, if I have coming sweat, you know, when I eat something very tasty, my bald head starts sweating. Which fibers are activated? Those fibers are coming from superior cervical ganglion around the internal carotid artery. No, external carotid artery, because internal carotid is going inside. And their branches which are going to the scalp, right? And there they will be giving to pseudomotor supply, right? Now come back. What is the clinical importance of this thing? Huge. Why? There is a condition called Erb palsy. We call it Erb's, E-R-B-S, Erb's palsy. And there's another condition which is called clump case palsy. Right? Now, from here, brachial plexus is moving downward and laterally towards the axilla, from the neck to the arm, through the axilla, right? As brachial plexus is moving down, this is brachial plexus moving down, this is upper trunk, this is middle trunk, this is lower trunk. If upper trunk is damaged, it means which fibers will be lost from the arm? C5, C6, right? This is called Erb's palsy. When upper trunk is damaged or C5 and C6 fibers are damaged here at this level, we say there is Erb's palsy. Now, how it can occur? This can occur when baby is being delivered, head comes out from delivery canal, but shoulder gets stuck. And if there is excessive manipulation of the head, then excessive separation of head from the shoulder right? There will be overstretch on the upper part of the brachial plexus, and there may be damage, there may be stretch, or even there is brutal manipulation, then it may be ruptured. So this damage will lead to Erb's palsy, right? Right? If we come here, that someone has undue abduction, separation of arm from the trunk, too much. Now here is, this is going down. If arm is going too much up, then this will be overstretched, which lower trunk. If, okay, let me make a diagram here. This is your beautiful body, and here is your arm, right? Okay, your legs also, beautiful, lovely legs. But what I want to say, here is your, what is this? Upper, middle, and lower trunk of brachial plexus. If head and shoulder, they are separated too much due to some accident, or during the delivery process, or due to some injury, if they are too much separated, upper trunk will be damaged. C5, C6 functions will be lost, and the motor and sensory loss which will result, that whole sensory and motor deficit with special, we will discuss later. We say the arm assume a special type of posture which is called policeman tip posture, or waiter's tip posture, or porter tip posture. I will explain why this happen, why this special. If C5, C6, it means upper trunk is damaged. If upper trunk is damaged, when it is damaged, when there is undue separation of head and shoulder, right? And it is either stretched or even ruptured, or there is some trauma, that will lead to the Erb's palsy. And here I want to say something. This area from here, yes, this area, when it is damaged, if there is damage in this area, in which there is upper trunk and two of its inputs, C5, C6 roots, and two of its outflow, that is anterior devian and posterior devian from upper trunk, right? Or two of its offshoots nerves. Okay, this I should reduce it. This should be up to here. Upper trunk is damaged, right? I will make it more dark. If upper trunk is damaged, if upper trunk is damaged, C5 and C6 are damaged. So actually what has happened, two roots lose their function, upper trunk loses its function, upper trunk, anterior devian and posterior devian lose their function. And what is this nerve going? I will teach you in next lecture. This is suprascapular nerve, and what is this? Nerve to subclavius. These are damaged, and this point, this anatomical location is called Erb's point. What is it called? Erb's point. So let me explain here. This is C5 root, this is C6 root. Both of them are making what? Upper trunk, and then upper trunk divide into two devian. This is anterior devian and this is posterior devian, right? And here was which nerve? There were two nerves going out of the upper trunk, right? Suprascapular nerve, and one was going down. What was that? Nerve to subclavius, right? Now, if there is injury to this region, we say there is injury to the Erb point, and this injury will occur when this is overstretched, or there is trauma, stab injury, or there is bullet injury, or there is overstretched, as I mentioned in delivery, right? This Erb point damage we say up point is superior trunk, which has two inputs, roots, two outputs, divisions, and two offshoots, nerves. This point where six nerves are 1, 2, 3, 4, 5, 6, they are meeting. If there is damage here, we say that there is damage to the Erb's point, and we say there is Erb's palsy. But we will have a full lecture on Erb's palsy and Klumpke's palsies later. Here just a little discussion. Now let's compare Erb's palsy with Klumpke's palsies. If shoulder become too much down and head become like this, which palsy you will have? Erb's palsy. But if it becomes too much like this, right, trunk and this is separated, and the lower part of the plexus is overstretched or injured, right, then injury will be in this zone. And if injury is in this zone, then what is this? Klumpke's palsy. But there is one thing, very important thing. You remember T1 was having what? Sympathetic fibers which were going to, and then these sympathetic fibers postganglionic were going to different type of what is this? Ganglia, right? Cervical sympathetic chain. If lower trunk is damaged, right, it means that not only C8 and T1 fibers function is lost, which I will explain later, that patient hand will take a claw shape, right? That will be explained later. But if this injury become more medial, this may also damage the sympathetic outflow. And if T1 sympathetic outflow is damaged, then all the sympathetic fibers which are going up, they will be damaged. And even sympathetic supply to the head, not only neck, but also to the head will be damaged. And that will make classical clinical picture in the eyes. What will happen to the ipsilateral eye if ipsilateral sympathetic nerve supply is lost? Number one, drooping of upper eyelid, because that is eyes are kept open by two mechanisms. Number one, levator palpebrae superioris somatic part, that you can open the eye as you want. Number two, eyes remain open once you open, that is sympathetic fibers, autonomic fibers. So drooping of the upper eyelid, number one. Number two, sympathetic fibers are pupillodilator. And when pupillodilator function is lost due to loss of upgoing sympathetic fibers, right, due to damage to the T1 or stellate ganglion as a part of Klumpke's palsy, right, then there will be pupillodilator fibers will be also damaged, compromised, and pupil will become too much miotic, small, constricted. So drooping of upper eyelid, miotic eye, with that ipsilateral face, vasomotor failure. These blood vessels don't have sympathetic, they will dilate a little bit, so they will flush more, and no sweating on this side, and hydrosis, right? So we can say, and this combination of features, again, what was there? Klumpke's palsy. What was damaged? What was damaged? Primarily lower trunk. And if injury goes medially, it will damage the stellate ganglia or T1 ganglia. When sympathetic outflow is damaged, it is no more going up, right? Head and neck ipsilaterally loses its sympathetic flow. But clinical signs come related with the eye, especially that there is drooping of upper eyelid, or we say ptosis of upper eyelid, and with that there is miotic or constricted pupil on one side, and with that half of the face is showing loss of vasomotor function, which lead to flushing or vasodilation, and also loss of sweating, which is called pseudomotor failure or anhidrosis, right? Now, we have just studied the basic structure and components of roots and trunk, and special, we try to make confusions clear related with the roots of the spinal cord. So what is clear today's, what I made clear in today's lecture? Ventral root, ventral horn, ventral root, dorsal root, spinal nerve proper, going into dorsal ramus and ventral ramus, and from C5, 6, 7, 8 and T1 is called, these ventral rami are called brachial plexus roots, right? And then we discussed about these roots somewhat different from each other, right, in detail. Especially sympathetic outflow is going through T1, and if lower brachial plexus is damaged, it can be accompanied with Horner syndrome. But if upper this is damaged, Horner syndrome will not be there. So if the brachial plexus superior lesions, upper trunk lesions don't manifest signs and symptoms of Horner syndrome, and if lower part of the brachial plexus is damaged, and if damage extend up to the T1 or stellate ganglion, then along with the clump-case palsy fibers in the dysfunction in the upper limb, you will also have Horner syndrome. And I hope in future you do not confuse the spinal cord roots with the brachial plexus roots. And this is, of course, it was very easy that root number 5 and 6 together make upper trunk, root number 7 continues as such and make middle trunk, and root number C8 and T1, they come together and make lower trunk. And just to remind, if upper trunk is damaged, which palsy? Earth palsy. And if lower trunk is damaged, clump-case palsy. Here you have to remember that there are 6 nerves which are meeting each other, right? And here you have to very specially remember that this can be associated with sympathetic outflow damage leading to Horner syndrome. Thank you very much. Next lecture, I will talk about roots and trunk. While they are passing through the neck, their anatomical relationship, right, in between the scalene muscles, and also clinical applications. And then I will talk about when brachial plexus is passing through supraclavicular triangle, right? When it is passing through supratriangle, what are the important relationships, especially with subclavian artery? Then brachial plexus enters through a very narrow space which is present between the clavicle and first rib, that is called costoclavicular groove, through which brachial plexus with some vessels is moving from the neck to the axilla. We will talk about those anatomical relationship and related clinical situations, right? That is our next lecture. After that, next lecture we will come to this, and in next lecture we will do the divisions also. After that we will come to the cords and branches, right? Thank you very much for listening.